Assalamualaikum and a very good morning to everyone here. Welcome to the breakfast at UMHealth, the 27th episode. And this morning we're going to listen to two eminent speakers, but I'm going to moderate the first one. It's going to be the topic on prenatal androgen exposure, a developmental etiology for polycystic ovarian syndrome. It's going to be delivered by Dr. Jerilee, one of our clinical lecturers in the department, and she has been the training for the pediatric adolescent gynecology, and will be going to finish soon the training, and will be heading the PAG unit later. And she has MRCOG and MOG qualification, and he's also graduate for the MBBS. So if you have any question, you can actually put it in the Q&A section, and I can read it out for you. And without further ado, I would like to invite Dr. Jerilee to deliver her talk. Thank you.
Assalamualaikum, very good morning. Thank you, Prof. Mukhri, for the very kind introduction. I don't see myself as an eminent speaker, but this gives me great pleasure to be able to speak to you. I find that the second speaker is actually speaking about night shift related fatigue. I just wish that she had speak first so that I know how to cope with this night shift fatigue, preparing the slides itself. Nevertheless, gives me great pleasure again to be introducing to you my topic, which is prenatal androgen exposure, the development etiology for PCOS. Before I begin any further, let me just give you a brief introduction what PCOS or polycystic ovarian syndrome is. It is the most commonest, most prevalent heterogeneous endocrinopathy. It affects at least 6 to 20% of women in the reproductive age group. Why we have this wide gap is because different countries, different practitioner uses different criteria to diagnose PCOS. In Malaysia, we use Rotterdam criteria, where you need to fit 2 out of the 3 criteria, which is polycystic ovarian morphology and ultrasound, hyperandrogenism, and anovulation. When we talk about the common symptoms of PCOS, it could range from irregular menses to no period at all, to having excessive hair on face and body, having losing hair, having acne, insulin resistance, obesity, and subsequently type 2 diabetic hypertension, infertility, ovarian cysts. And you can see when you combine all these symptoms, it's no wonder that these women sometimes suffers from anxiety and depression itself. So previously in school, during medical school, we've been taught to remember infamously that PCOS women are obese and hairy and infertile. But you don't see this among our celebrities. They're beautiful. Maybe because they exercise and they keep a healthy lifestyle. Victoria Beckham here, for example, has gone for IVF for her PCOS condition. Now, let's talk briefly about the pathophysiology of PCOS. The fundamental base function how PCOS works is because of androgen excess. It could come from a lot of other factors. It could be due to genetics or obesity or sedentary lifestyle that subsequently increases the insulin and the insulin resistance, forcing a woman to become type 2 diabetic, dyslipidemia, and heart disease as well. Androgen excess can stop folliculogenesis at antral stage, and therefore you have all these antral follicles surrounding the periphery of the ovaries, causing what we call a string of pearls, where you can find ultrasound findings. This is an example when anovulation takes place. There will be also an ovulatory bleed. There will also be a decrease in progesterone release, and therefore an unopposed increase in estrogen that leads to endometrial CA. In this slide, we've shown some treatments, including metformins, some COCPs, anti-androgenic treatments, and we also have some induction of ovulation treatment right here. So my previous slide already tells you a lot of problems can occur, but unfortunately it occurs throughout a woman's life, from the very young age to the very old age, from menstrual disorders, affecting their school life, for example, taking contraception for teenagers, for example, sexual health, and when they grow a little bit older, infertility, and the older they get, they have other complications related to metabolic syndrome. The prevalence of metabolic syndrome in Malaysia in PCOS women is as high as 47.4%. We are the highest among all other countries. Earlier, I've mentioned to you there are a lot of criteria used to diagnose PCOS. In 1990, NHI came up with a certain criteria. Rotterdam, what we use today, came out with the 2 out of 3 criteria. And quite recently, not so recent, probably about 10 years ago, AE-PCOS or androgen excess PCOS came out with their criteria. But if you look at all these criteria used around the world, hyperandrogenism must be present. It means that androgen is crucial in diagnosis of PCOS and crucial in pathophysiology of PCOS. So when I see patients in the clinic and I explain to them one of the things that can cause their symptoms is increased androgens. They ask me how did the androgens get there in the first place, and I'll be sweating because really, it's multifactorial. It's very complex, and I don't know where to start. So I would tell them things like, it could be from the environment, it could be from genetics, it could be from some gut dysbiosis and lifestyle and diet and all that. So those patients are not very, they can't really tell which is, they start blaming themselves. So when we're counseling patients, we really need to be sure that we know what their levels of testosterone is before we do that. But there is another way. There's a possibility that a fetus or child receive androgens from their mother if the mother have excess androgens while they're getting pregnant. So in this chart itself, you can see that the transfer of androgens to the fetus causes cardiac hypertrophy, hypertension, insulin resistance, hyperlipidemia, and obesity. Let me give you a brief introduction what PNA exposure is, or prenatal androgen exposure. Now, androgens is crucial for embryogenesis, or the development of the fetus, especially for reproductive tract and its organ, kidneys, bone, and muscle. The maternal serum testosterone in the first trimester will increase, and it will remain high throughout the pregnancy, irrespective whether the fetus is a female or male. It will peak at third trimester and will come down slowly at postpartum. The range of maternal serum in pregnancy itself, both for male and female, ranges from 0.5 to 2.1, around that. So, despite this increase in both total and free testosterone during normal pregnancy, woman carrying the fetus has got no issues with that condition. So how does the fetus protect itself from this high level of androgen intrauterine? 3 ways. They increase SHBG, or sexual hormone binding globulin, that binds to testosterone and DHT, reducing free androgen index. Or they use placenta aromatase cytochrome P45 to counteract the excess of testosterone in DHEAS, converting it to either E2 or E1. And unless there's an abnormality in the adrenal or ovarian function that leads to excess androgens by the mother or the fetus above the capacity of these protective measures, then there is a chance that there is a hyperandrogenic state intrauterine. This concept was first introduced to us by Swanson et al. In 1964, and he termed it as early androgen symptoms. So we counsel a patient who is pregnant now, a PCOS patient who's pregnant now, about all the complications that can be related to PCOS pregnancy. They ask, what happens with the excess androgen intrauterine? This is a very busy slide, forgive me, but it is the slide that could actually demonstrate all phases of pregnancy, fetus, and adulthood. PCOS women who are pregnant could predispose to pregnancy-induced hypertension, preeclampsia, gestational diabetes, as well as preterm labor. Babies born or neonate born to PCOS mothers, they are at risk of IUGR, growth defects. They can be big, large for gestational age. They can be small, small for gestational age. They could have cardiovascular diseases, metabolic dysfunction, and when they go up to adulthood, and these are the adult consequences, you can see right here on the reproductive side, brain, pituitary, ovaries, there is multifollicular ovaries, oligo and ovulatory, and reduced fecundity. All this showing to the signs of PCOS. So we now think that daughters of women with PCOS face a higher risk of developing PCOS themselves. Therefore, there was a trial in Swedish, a nationwide registered based cohort study to assess whether daughters of PCOS women are more prone to be developing PCOS, and the answer is yes. Not only that, they have a higher body mass index, larger waistline, higher diastolic blood pressure, higher Ferriman-Gordon score we use for hirsutism, higher free androgen index, higher AMH. They are more prone to developing neuropsychiatric disorder and a longer anogenital distance, which I will introduce to you in a bit more. This was a study done, and you can see that daughters born to women with PCOS have fivefold increase of PCOS compared to the control one. Over on the left hand side, you can see they are more likely to be hyperandrogenic, oligomenoric. They probably will have polycystic ovarian morphology and ultrasound, and they're more likely to be diagnosed with PCOS in their adulthood. So, what can we do? We know there is a possibility of developing PCOS from prenatal androgen exposure. Is there a particular thing we can look out for? Is there a marker that we can use? Something cheap, something easy to use, something non-invasive, something that's acceptable in our patients? Fortunately, yes. We have what we call the anogenital distance. The anogenital distance is defined as the distance between the anus and the genital tubercle. In this diagram, is between the clitoris to the anus or the posterior fornix to the anus. In early development of external genitalia, whether female or male, it doesn't make a difference. But later on in the fetal life, it will depend on Y chromosome of the SYR genes. Testes will develop in male, obviously, and testosterone in female comes from fetal adrenal or maternal adrenal ovaries or adipose tissues. What is interesting is the androgen effect in the development of perineal tissue increases the distance between the anus and the genital tubercle. Therefore, anogenital distance can serve as a lifelong indicator of androgen action in the gestational week between 8 to 15. There are many evidence now showing an elongated anogenital distance in daughters of PCOS mothers. Many studies from fetal stage to neonatal stage to adult stage, all saying when compared to control fetus, control neonates, or control adult from mothers of PCOS offsprings, they tend to have a longer anogenital distance. They even came out with a systemic review as to how and what kind of condition would have a elongated one or a shorter anogenital distance. Here, in relation to gynecological disorder, AGD is longer in PCOS and shorter in endometriosis, especially in deep infiltrating endometriosis. The question really now is, if the fetus were exposed to prenatal androgen exposure and then develop PCOS in their adulthood, when do the development of PCOS actually start? Does it start immediately on birth and then show itself later on in their reproductive life? So we at University of Malaya and University of Tokyo actually come together and start investigating or try to answer this question. What we did was we did a temporal relationship between the alteration of gut microbiome. I'm really sorry, but it is not in the scope of our talk to talk about the gut microbiome, and the development of PCOS in PNA. This was a mouse project, and my role in this study was to develop a PCOS mouse model long enough to get them pregnant, to be able to produce mice of 4, 6, 8, 12, 16 weeks, representing prepubertal, pubertal, adolescents, young adults, and adults. And then we look into their PCOS-like phenotypes, reproductive and metabolic, and gut microbiome. What we actually found is that polycystic ovarian morphology starts to show itself at puberty itself, not at adolescence. Testosterone starts to increase its concentration at puberty, not at adolescence. What's more interesting that the biomicron changes starts at pre-puberty. So we're talking about development of PCOS as young as 11 or 12 years old and changes of microbiome at babies or kindergarten girls from PCOS mothers. So what's the point of us doing all this? First of all, we now know that PCOS may originate in intrauterine life, and it could be one of the effects of prenatal androgen exposure. And since we have a way of sort of like a marker for us to identify PNA exposure or prenatal androgen exposure, will allow us to have some sort of early intervention, preconceptual counseling, for example. PCOS mothers who's now pregnant, what can we counsel them? Preconception intervention. Tell them, lose weight, control your PCOS, control the level of androgens first before you embark on a pregnancy. When they do get pregnant, maybe we have to have some closer antenatal monitoring, making sure all the complications related to PCOS pregnancies at a lower range. When the baby is born, we educate, we counsel about healthy lifestyle in childhood, trying to avoid the incidence of obesity and so on. Of course, there's a role later on in the future, maybe probiotic, symbiotic, or prebiotic treatment for the gut microbiome dysbiosis PCOS offspring. The latest guideline has actually talked about evaluating other family members from a PCOS mother. This is the international evidence-based guideline for the assessment of and management of PCOS in 2018. You can screen for the, you can actually scan the QR code for the full guideline. It has finally included PCOS in adolescents. It says that ultrasound cannot be used because of the multifollicular ovaries in the stage. Irregular menses can be absolutely normal in adolescents, so we can't use irregular menses as one of the criteria to diagnose PCOS. But fortunately, we can use androgen profile. It also includes management of PCOS in pregnancy. There are many gaps to fill, and in our department, we're focused on trying to investigate the role of PNA or prenatal androgen exposure in metabolic syndrome, for example. In this study, we have already found that there is a 4 times increase in the prevalence of metabolic syndrome in women with PCOS and a longer AGD. We're also trying to come up with a lot of other studies related to PNA, especially genital distance, outcome of ART or artificial reproductive technique in women with longer AGD. But what is more interesting now, they are coming up with a term called male equivalent of PCOS. It's a rising concern because they have found that male equivalent of PCOS may present the same way as a female PCOS. Brothers of PCOS women we're talking about. So does PNA play a role in this brothers of PCOS women itself? So if you're interested and you want to collaborate with us, please come and join us. We're in the KKWK 7th floor. Or you can write to me. These are my emails. I've been told to speak between 20 to 25 minutes. Maybe I have keep up with time, Professor. Have I? Thank you very much.
Thank you very much, Dr. Jerry, for the nice, short and sweet talk. So, for those who have any question, you can actually type it in the question and answer chat box. So, to start with, we have a question here. It's from Prof. YK. That the question is: can the hormone levels in the parturient impact on the development of gay and lesbian preference later in life?
Prof, that's an excellent question. There was a paper recently just came out, I think February 2022. They look up gender dysphoria in relation to prenatal androgen exposure, and the answer to your question is yes. It affects male more than female. I can't find the answer why it affects male or female, but it also says that the androgenital distance in male is much longer than the female, maybe because of the anatomy as well, but because of the testosterone is also higher in male compared to female. So that could be one of the possibilities. But there's only one single study that's been done recently.
Okay, thank you very much. And I think Prof. Tunku Sarah actually also asking that probably you have answered it before, that she asked actually what happened to sons of polycystic ovarian syndrome patients. So is there any evidence now, or we still need to do more research on that?
The term male equivalent PCOS just came out probably in the year of 2018, I think, when they start seeing brothers of PCOS women were infertile. They look a little bit on the bigger side, they're obese. But because the term PCOS, the word ovaries are there, and when you scan, you see an ovarian morphology. In the male, they would look at the Leydig cells. That will mean you will have to take some cells from the testis to have a look at it, which is not possible in human samples. So what they are doing now, they're actually monitoring testosterone level they're looking at insulin resistance, they're looking at all the metabolic syndrome, and they're looking at their fertility rate as well. But yes, there is a term called male equivalent PCOS. Uh, in our department, we are in the process of trying to get a grant to evaluate the brothers of PCOS women and see how much does it affect in terms of PCOS female, for example. So far in Malaysia, we have not had any studies done, and we're hoping that we could get this grant and initiate the study soon.
Okay, thank you. So there's a question here that it actually asks whether the anogenital distance can be used to identify risk of PCOS in offspring of a woman who are not previously diagnosed with PCOS, meaning that if the offspring is actually delivered from a mother without PCOS, is the distance is actually can risk stratify whether he or she can develop PCOS in the future.
Oh, that's a tough question. I've showed you in one of my slides of the Swedish cohort study. They show that if the mother doesn't have PCOS, control mothers, they are less likely to have elongated AGD. If you don't have an elongated AGD, then the risk of developing PCOS, according to that study, is not as high as somebody who has got a mother with PCOS. So if that particular woman who's got a shorter or a normal AGD develops PCOS, it could be from other factors. It could be from environment or from lifestyle and all that. But maybe it doesn't come from PNA or prenatal androgen exposure. That's why in our study, what we did was we took two groups of PCOS women, one with metabolic syndrome, one without metabolic syndrome. And we know that not all PCOS women has got metabolic syndrome. So we wanted to know whether PNA as an intrauterine exposure makes this woman more prone to become metabolic syndrome or not, as compared to also PCOS but not metabolic, but doesn't have metabolic syndrome. Same kind of a scenario in terms of who will get PCOS and who will not. I hope that answers the question.
Okay, I actually have a question myself. So you are telling us all that it's prenatal exposure of the androgen. So with this is what you mean is before they embark with the pregnancy or during the pregnancy. So since prenatal means they have not embarked with the pregnancy, so the androgen is exposed to the ovary rather than the embryo.
Yes,
What do you mean by PNA, the prenatal in this
it
study?
means that it means that a PCOS woman would have already a high level of testosterone before the pregnancy itself, and then they become pregnant. And when they become pregnant, more testosterone is going to be developed because of the changes in the pregnancy itself. So now you have a doubling effect of an increase in estrogen. So that's why we think that PCOS mothers, or women with CAH, for example, or a women with adrenal tumor, for example, that has this high level of androgens in them and embark on pregnancy, it doubles this number.
Okay, so many of the patients with PCOS still can get pregnant. So we don't actually know about her androgen level. So do you recommend to check the level of androgen for all women going for pregnancy, or at least those who are obese, not PCOS, but has obesity or some features but not fit in the Rotterdam criteria?
I guess it helps in your counseling with your patient if you have a higher level of androgens, right? You can say that let's just put PNA aside. Even without PNA aside, androgens itself will cause some degree of obstetric complication, preeclampsia, BIH, and GDM. So you could take for the basis of counseling, but I don't think it will change much of a management in obstetric. Just the counseling part. Maybe you should lose some weight a little bit, control your PCOS first before you embark on the pregnancy, take folic acid, the usual preconception counseling.
Okay, there is a follow-up question by Prof. YK here. So is the uh, is there is a testosterone level in males make left-handedness more often seen more in this sex than females?
Can I be honest, Prof? I don't
Mhm.
know.
Okay.
I don't know.
And
Sorry.
and do they have a predilection to renal dysfunction? If is in that they will also more likely to have polycystic kidney.
Got it. I think there was a comparative study of prenatal androgen, PCOS, and Mullary anomalies. And I think with endometriosis, they found that there was no connection between prenatal androgen exposure with Mullary anomalies. And if you talk about Mullary anomalies, one of the condition is what we call OVIRA, obstetric hemivagina obstructor with ipsilateral renal agenesis. So the girl is born with only one kidney. So in that case, in that study, it did not say, or it doesn't agree that PNA or androgen exposure predisposed to that. That's the only condition where I think there is some studies done.
Okay, there's no more question in the box. So as you know that the Rotterdam criteria is actually more to clinical, like polycystic ovarian morphology, hyperandrogenism, and one more thing is the irregular menses. So we don't actually need to measure androgen levels to diagnose PCOS, because clinical hyperandrogenism is actually adequate to diagnose that. So maybe we need to do androgen level, because hyperandrogenism clinically doesn't mean that you got hyperandrogenism, right? So
Correct. Correct.
probably all PCOS, if because Rotterdam is actually put out clinically so that we don't have to do any blood test. But now with your recommendation of prenatal androgen exposure, so we probably need to look whether they have higher androgen and make it lower before they embark with the pregnancy. Is it what you recommend, or what?
When you talk about clinical hyperandrogenism, one of the things we look at is hirsutism, and we know that hirsutism has got a wide range in ethnicity. One person could be, a little bit hairy, but she doesn't have PCOS at all. And if you look at the Japanese patient, for example, super clean shaven, and they're also PCOS. So we're getting away from using clinical hyperandrogenism in terms of hirsutism. If a hospital has got the facility to test for testosterone at a reasonable price, I think there's no harm. Unless we have no choice, but we don't have that facility, then we could use clinical hyperandrogenism as a marker as well.
Okay, thank you very much. Thank you, Dr. Jerilee, for the kind of nice talk and update for us. So I think that's all from me. So I'm going to pass it over to Prof. Muhaimin for the next session. Thank you very much.